Byron J. Powell, here we go. So when I read my first Powell article a couple of years ago, I was, and I haven't told you, but I was totally convinced that that was written by some senior guy with lots of experience, long track record. I was surprised that I hadn't come across your name, but I kind of thought, oh, that's my mistake. He must have produced a lot. And then I met Byron last year at a conference and kind of figured out, oh my God, he's young. He's young, he's in his 30s. And he is part of this pretty cool implementation scientists crowd, young emerging scientists who are going to rock the boat in implementation science in the coming decades. And he was nice too. So that made it quite an easy choice for us to say, hey, let's invite him to open this conference today. Byron finished his PhD 2 years ago. He's young, he is. Based on, and this is the title, a mixed methods multiple case study of implementation as usual in children's social service organizations. And on his dissertation committee were people like Enola Proctor, she was his chair, Ross Brownson, Charles Glisson, so some of the big names in evidence-based child welfare and implementation science. Pretty impressive. He recently moved to the Gilling School of Global Public Health at the University of North Carolina, where he is an assistant professor in the Department of Health Policy and Management today. And in implementation science circle, he already goes by implementation strategy because of his extensive work with defining and cataloging distinct implementation strategies as the building blocks of implementation. And his presentation was much on this today. What I also find remarkable about his work is interested in creating a better understanding of the policy context surrounding any implementation process, and that entire context is probably least explored and understood by the field of implementation science. And I find it very encouraging to see that change in, among others, Byron's work. So with this as a kickoff, you can raise and come up here because it's all yours, and have fun.
So thank you so much for that kind introduction, and thank you for the opportunity to be here. Special thanks to the planning committee and to the board for inviting me. It's been a pleasure to be in Denmark, and I only regret that I'm here for just a few days. It's been wonderful thus far. So just to give you an overview of what I'm going to talk about today, I'm going to start with a basic introduction to implementation science and just present some definitions just to make sure that we're on the same page. Then I'm going to spend some time talking about a few studies that we've done to develop and refine a compilation of implementation strategies. I'm going to then transition to discussing how we can apply those implementation strategies in practice and some studies that we've conducted to hopefully improve the way that we apply them in practice and research. Then I'm going to move to talking about how we can improve the reporting of implementation strategies in the literature. This is a very important area in my estimation, and so I'm going to share some of the work that we've done in that area, and then discuss some priorities for moving forward briefly. So I know that we can all debate about the role of evidence in practice. I think that we can all sort of coalesce around this definition of evidence-based practice from David Sackett that many of you know, which is really the integration of clinical expertise, best research evidence, and patient values and preferences. So that's really what we would like, I think, in all of the spheres that we're working. What we would like to avoid, of course, is our research languishing on the shelf, the quality chasm, and of course the valley of death, which I think there are probably many more metaphors that we can use to describe the gap between research and practice. But these are the things that we'd like to avoid. And I think implementation research has entered as a promising way of addressing the gaps in quality that we face in our various sectors. I often refer to this definition of implementation research in the journal Implementation Science by Eccles and Mittman, which, paraphrasing it, which is really the scientific study of the methods to improve the integration of effective practices or other evidence-based treatments into routine care. And this includes the study of influences on provider behavior, organizational behavior, and sort of the multi-levels of behavior change that we need to accomplish for effective implementation. Another model of implementation that I often refer to was developed by Noah Proctor, my mentor at Washington University. And I think one of the important things that this model shows as you look at the left-hand side boxes is that there's a separation between two different types of important interventions. So there's the evidence-based practices or the other effective practices that we're trying to implement, and then, which is really the what that we're trying to implement, and then the implementation strategies, which is the how we're actually going to implement those things. It also, I think, does a service to the field by separating out the different types of outcomes that we often like to examine in implementation research. So the implementation outcomes often focus on things like, can we improve the acceptability, appropriateness, and feasibility of interventions? Can we improve fidelity? Can we improve penetration and sustainability? And we assume that if we do that, we will actually make many improvements in clinical outcomes or the stakeholder outcomes that we would like to see. So obviously today I'm focusing on implementation strategies, which we've defined as methods or techniques used to enhance the adoption, implementation, and sustainability of a clinical program or practice. We've differentiated between multiple types of implementation strategies. So we talk about, in our work, discrete implementation strategies, which involve single actions or processes. So these are things like institute systems of reminders, a training workshop, consultation, strategies like that. We also often see multifaceted strategies. So we know that implementation is complex and that there are barriers at multiple levels. So effective implementation often involves the use of multiple strategies. So combining multiple discrete strategies such as training plus reminders and so on and so forth. I'm quite sure that we made up this term blended, but we talk about blended implementation strategies to refer to those implementation strategies that have been protocolized in some manner. So many have been named and protocolized. Some of you I know are familiar with the Institute for Healthcare Improvements Breakthrough Series Collaborative. Another mentor of mine, Charles Glisson, has a strategy called the Availability, Responsiveness, and Continuity Intervention that's designed to improve organizational culture and context in the service of improving clinical care and children's mental health. And these are what I refer to as blended strategies. So the initial question that really drove this work to develop a compilation of implementation strategies was driven by community stakeholders who were asking, in response to a real shift at our school, which focused on really starting to implement evidence-based practices, they were asking, what are the evidence-based strategies and what strategies can be used to implement these effective practices? And when we looked to the literature, we faced a couple of problems. So the first problem that we saw was a lack of conceptual clarity in the literature. Literature has been referred to as a Tower of Babel, people really talking past each other. And one of the challenges is that strategy terms and definitions have been used inconsistently. So sometimes we might have a strategy that is labeled one way but talks about many different things. And at other times we might have strategies that are labeled entirely differently, but they're talking about the same thing. And so there can be a lot of confusion in the field. Compounding that confusion is that strategies are often poorly described in the literature. So just like we would like to see, a careful description of clinical practices or other programs that we're implementing, we really need clear descriptions of implementation strategies so that we can replicate them in science and practice. And when we turn to methods such as systematic reviews and meta-analyses, it's important that we have a sense of what the strategies involve, what the core components are, and how you might actually do that in practice. The other problem that we faced was what we thought was sort of a limited menu of strategies in the literature. So many of the compilations and reviews that we saw seemed to focus on things like training and supervision, and maybe this is an artifact of us working in the field of mental health and addiction services, where these are sort of the dominant modes of implementation. We often refer to them as the train and pray or the train and hope approaches to implementation. And we thought that there was a need for a much more extensive menu of options for implementation. So the first study that I'm going to discuss was a structured review of the literature, which actually involved first going to the compilations and lists that we were aware of. So the Cochrane Collaboration's Effective Practice and Organization of Care Group has a taxonomy called the Data Collection Checklist. And so we started with that checklist and moved to other books, articles that we were aware of, searching out compilations and lists that we could actually cull the discrete strategies from. We also looked at some of these blended models that I referred to and similarly tried to cull the discrete strategies from those. We supplemented this initial search with a database search using a structured approach, as well as an expert query, which really amounted to us asking the editorial board of the journal Implementation Science if they had any recommendations for literature that we should be paying attention to. This paper was first published in 2012 in Medical Care Research and Review, and essentially we laid out 68 discrete strategies, and so we grouped these into 6 categories. So many of these strategies focused on planning and really the early stages of implementation, and focused on things like gathering information, actually selecting the discrete strategies that you're going to use, building buy-in with community stakeholders, initiating leadership and ensuring proper leadership of implementation efforts, and developing relationships with key stakeholders. Of course, a number of these strategies focused on education, again, noting the dominance of training in the implementation literature, but also approached education in different ways through opinion leaders and champions and other discrete strategies focusing on educating through various delivery mechanisms. Financing, of course, is a crucial part of implementation, and so we had actually a number of strategies that focused on financing. There were also a number of strategies that focused on restructuring, both the physical environment of sometimes clinical settings, and also things like the makeup of clinical teams, restructuring to ensure that there were adequate professional skills available to deliver certain programs and practices. And finally, as Bianca mentioned, we included some strategies that focus on the policy context. And this is something that I actually regret with this compilation that I don't think we addressed very well. I think there are actually a number of other strategies that can focus on policy issues that we haven't included to date. And one of the limitations of this initial compilation is that it really wasn't informed by a broader group of implementation experts. So we had an interdisciplinary team of social workers and health services researchers and emergency medicine physicians on this paper. So we felt like we had some diverse perspectives, but wanted to really vet this with a broader range of experts. And we had an opportunity through a study called the Expert Recommendations for Implementing Change Project, which are really colleagues from the Department of Veterans Affairs in the US. We had an opportunity to refine this compilation. So the first stage of the ERIC project was to establish expert consensus on a common nomenclature for implementation strategy terms and definitions. And the first part of this project really involved developing an expert panel, and we did this by propulsive sampling, first starting with the editorial board of implementation science. We also involved implementation research coordinators at the Department of Veteran Affairs query centers, and these are folks that are really working at the intersection of implementation science and practice. They're people that are implementing evidence-based practices on a large scale within the Department of Veteran Affairs in the US. We also involved faculty and fellows from the Implementation Research Institute, which is a training institute focusing on implementation science in mental health and addiction services. Ultimately, we had 71 participants. And I think another critique of our participant pool is obviously this is very US-centric and North America-centric. We had a couple of participants from Canada, but this is shameful to say the least, especially in this context. Thought about deleting this slide, but in full interest of full disclosure. So the first part of this study was to engage in a 3-round Delphi study. So this was initially seeded by our 2012 paper and the strategies and the terms and definitions from that paper. And the first 2 rounds involved asynchronous surveys in which we gave people the strategy terms and definitions and asked them to critique them, to suggest any changes, and also to suggest additional strategy terms and definitions if they found the compilation to be incomplete in any way. After each of those rounds, we fed that data back to the participants, as is consistent with the Delphi method. And then the third round actually involved a live polling and consensus process by which we used GoToMeeting to get everybody on the phone and vote on the strategy terms and definitions that had any suggested changes. We ripped off a voting procedure decision guide, I believe, from the US Senate, and why we decided to do that, I'm not sure. But really it was out of lack of better options that were research driven, but this gave us a systematic process of determining consensus. So just to share a little bit about the results, the majority of the terms and definitions from the original compilation were considered no contest and weren't subjected to voting, so people really didn't have concerns about them, and so we didn't discuss that in the final meeting. 21 strategies and 5 new strategies were actually voted on in round 3. And the alternative definition was selected the majority of the time, and each new strategy was retained. So ultimately, the refined compilation included 73 discrete strategies, and that's published here in Implementation Science. And I note here on this slide, Implementation Science often includes these supplemental files, and the most complete version of this compilation can be found in additional file 6 of that paper, if you're interested in reading more about this. The second opportunity we had to advance this compilation was to actually develop conceptually distinct categories of implementation strategies and start to develop some ratings, at least based on expert opinion, of their feasibility and effectiveness. And as Bianca cautioned at the beginning of this meeting, I think we need to take the evidence seriously. Not all of these strategies would be considered evidence-based, and I think some of them have a very robust evidence base, some of them have virtually no evidence base, and so I urge you to keep that in mind as you review this paper. So the approach that we took to developing conceptually distinct categories is an approach called concept mapping. I'm not sure if many of you are familiar with this. This is not something that I was familiar with before this study. But essentially this involves structured sorting and rating tasks. And so we asked people to take all of these 73 strategies and sort them into piles that made sense to them. And then there are some mathematical techniques called hierarchical cluster analysis and multidimensional scaling that are used to analyze this data through a software called Concept Systems Global. And basically what this does is develops a list of different cluster solutions that group the strategies that are more often rated together into these clusters. So what you see here, each of the dots and numbers are actually the 73 strategies. Strategies that are sorted closer together are more highly related. Geography matters on this map, so if you look at the sort of the southeast part of the map, that's quite different than the northwest part of the map. And so just to provide you a concrete example of what one of these clusters includes, so we had one that we named Provide Interactive Assistance, which involved centralizing technical assistance, facilitation, providing clinical supervision, and providing technical assistance. The other opportunity that we had was to get each of the participants to rate these strategies. And so what you see here is the average cluster ratings for these strategies. One of the interesting things that we saw was that utilized financial strategies and changing the infrastructure were perceived to be not very important and not very feasible. And it's certainly possible that the importance rating was driven down by people's sense of that it wasn't really feasible to they didn't have much say over financial aspects of implementation or some of the infrastructure issues. But things like use evaluative and iterative strategies, providing interactive assistance, and adapting and tailoring to context were seen as more important and feasible. This is another view of the data that is called a go zone map. And so what you see here in the upper right-hand quadrant are the strategies, that green section. are the strategies that were above the mean for both importance and feasibility. So we'd want to take a particular look at those, as well as some of these strategies that were below the mean in both feasibility and importance, as maybe we want to spend less time and attention on those. So for example, a strategy such as start a dissemination organization, obviously that's not something you do in a day, was not seen as very feasible or important, whereas things like assess for readiness and identify barriers and facilitators and audit and feedback were seen as highly important and highly feasible. So we've published this also in Implementation Science. If you'd like to take a closer look, I know I can't really do justice to either of these papers in this brief time. So if you'd like to check it out, feel free to do so. So we hope that this compilation and the refinements of it have some utility for both implementation research and practice. And again, one of the things that we hope is that it's useful in helping people to identify implementation strategies that they may not have thought of. If they're used to sort of the usual implementation strategies such as training and supervision, hopefully it sort of expands their horizon in that regard. It's also been used to track implementation strategies prospectively or retrospectively. So in the course of any implementation effort, we're often interested in what does it take to implement this well. And so I've been working with colleagues in various spheres to track implementation prospectively and seeing what types of strategies people are actually using throughout the course of a project. We hope that it can be useful in building multi-level, multifaceted strategies. So again, using the metaphor of the building blocks, oftentimes many of these strategies are going to need to be combined in creative ways to implement effectively. And so we hope that this provides some language and some tools to do that. As well as for research, developing intervention conditions for comparative effectiveness trials involving implementation strategies. We also hope that it highlights under-researched strategies. So again, the evidence for these strategies varies considerably. So strategies like audit and feedback and educational workshops have numerous randomized controlled trials to support their effectiveness or highlight their ineffectiveness, as it were. Whereas many of these other strategies are not highly researched, and so hopefully it provides us with a window into some opportunities for further research. Finally, as we think about fidelity of implementation strategies, just as we think of fidelity of clinical interventions, we can also think about fidelity of our implementation approaches. And the better we can sort of describe and report implementation strategies, the closer we will be to actually understanding what it takes to be faithful to the implementation strategies that we undertake. So moving on to some of the applications of this compilation and our work to think about how to more thoughtfully apply implementation strategies. And I often quote, this is from Martin Eccles via Jeremy Grimshaw at a training that I attended, who said that implementation strategies are often selected based on the Islagiat principle, or if you've seen this before, it seemed like a good idea at the time. And obviously we would like to move the needle in this area and hopefully be more thoughtful about how we select and apply implementation strategies. And ideally that would take into consideration the context, both the programs and practices that we're implementing and the specific features of the context that we're implementing in. Of course, it would also incorporate theory and very much looking forward to Dr. Nielsen's talk this morning about theories, frameworks, and models, and I think that will be informative in terms of how we can apply implementation strategies. And of course, we would also like to integrate available evidence, recognizing the limitations of evidence to guide strategy selection at this point, but we do have considerable evidence for some strategies, and that should really guide our practice. So there has been talk about moving towards tailored approaches to implementation, and there's actually been a fair amount of research in this area, though I think we need a lot more. And just to give a pragmatic example of what this looks like, of course, if we have something like a lack of knowledge, we may want to address this with educational, interactive education sessions. If there's a mismatch between perception and reality, so in healthcare, physicians or in mental health, clinicians often say, we're already doing evidence-based practice, we're fine, we're good on that front. Well, sometimes audit and feedback can be helpful in pointing out any gaps in evidence-based or guideline concordant care. If there's a lack of motivation, incentives and sanctions might be helpful, and so on and so forth. So I think this approach is intuitive and is increasingly being tested empirically. A review, and I realize this is almost 10 years old now, from 2007, suggested that when looking at tailored approaches to implementation, there's actually often a mismatch between the barriers that people identify and the actual strategies that they use. So they might identify barriers at the organizational level, but then attack that with more training at the provider level, and rather than sort of intervening at the organizational level. So there's been many suggestions that we need systematic and rigorous methods to actually improve the linkage between identified barriers and change strategies. And this is where I see sort of my work going in the future, and I'm hoping to make more contributions in this area. Continuing to discuss this ERIC study that I've referred to a couple times already, one of the opportunities that we had was to use a method called menu-based choice, which is a variation of conjoint analysis, which is drawn from sort of the marketing literature. One of the opportunities we had was to think about how we can derive recommendations for implementation strategies for 3 different clinical interventions in different contexts within the VA, and for different stages of implementation, thinking that, of course, they may need to vary based on stage. And so what we did was develop different scenarios, so vignettes of different scenarios of VA settings. And we varied evidence and context. Now, of course, the evidence for these 3 clinical practices that are listed here: metabolic monitoring, which is for individuals who are taking antipsychotics, measurement-based care for depression in primary care settings, and prolonged exposure for individuals with post-traumatic stress disorder. Of course, the evidence for those clinical practices don't change, but we know that the perception of the evidence can change greatly from site to site. And so in some sites we said, this site has a very poor belief in this evidence and isn't really buying it. In some sites we said they completely believe this evidence and are ready to adopt it. We also varied context, so things like leadership, culture, and evaluation capacity. And so we varied these things systematically and basically asked people, using a somewhat onerous task using Microsoft Excel, to select the different strategies that they would recommend in these different stages of implementation for these specific treatments and in these different contexts. And what we found was that what you see on this slide are the individual recommendations for strategies. And so what you see on the left-hand axis there is the number of strategies. And so you can see for depression, for instance, if you're looking at this green bar here on the left, you can see that there was a range of about 55 strategies that somebody thought 55 of the 73 implementation strategies were absolutely essential for implementing prolonged exposure for depression, and ranging to a low of 5 strategies. So there was great variation in the number of strategies that people recommended, and I think we were somewhat surprised at such a high number of strategies being recommended. When you actually aggregate this data and look at it in terms of whether the majority of participants actually endorse things as absolutely essential, likely and essential, or absolutely essential, what you see is that there's, again, tremendous range of strategy endorsements, but that anywhere from 11 to 24 strategies, depending on the clinical scenario, were deemed as absolutely essential. And there's this light green portion of all of these pie graphs here suggests that there are many strategies that are sort of discretionary for these folks that may be essential, but really depends on the context. And so what you see here are the concrete examples of strategies, and we did see variation between these different treatments, suggesting that different treatments and interventions may require different implementation strategies. Of course, some of these strategies were recommended across all 3 interventions, so we may want to focus specifically on those and prioritize those as important strategies in our work. So assessing for readiness and identifying barriers for facilitators, audit and feedback, conducting local needs assessment, and facilitation were all seen as important, as well as tailoring strategies were seen as important across all 3 interventions. Additionally, identifying and preparing champions and conducting ongoing training were seen as important across all 3 interventions. Similarly, we found that some implementation strategies were deemed absolutely inessential. So some things like alter patient consumer fees and change liability laws were deemed as absolutely essential across all 3 interventions, which we found informative as well as we focus on planning implementation efforts in those settings. So we were able to produce distinct results based on these different scenarios, and I should have said at the outset, we're still sort of in the thick of things in terms of data analysis, so this is really preliminary results from this study, so hopefully I'll have more to share with you in the future. But our initial finding was that we are able to produce distinct recommendations, and we found it helpful to think through the types of strategies that may be important in these different settings. We did find that experts endorsed a much higher number of strategies than we had anticipated, and this is actually much higher than the number typically tested in trials of implementation strategies. And it actually, we think, may reflect an underreporting of strategies in trials. So we might take a lot of these strategies for granted, and trials that actually involve, a test of 3 to 5 implementation strategies may actually involve many more that just go unreported. The high number of strategies also seems to be consistent with the number of discrete strategies that are reported in real-world implementation efforts. So though we may test only a few strategies at a time, when we have sort of descriptive anecdotal reports of implementation strategies, often they report that it does take a lot of these strategies. And so I think the implication of this to me is that we need to get real and sort of be honest with ourselves about what implementation really takes. And of course, cost considerations are important, but many times implementation does take a lot of work on a lot of different levels, and we need to be clear about what is involved. Despite the fact that this research task was somewhat onerous and took a lot of time, participants actually wanted more context, so demonstrating the importance of context in implementation research. We really need to tailor the strategies to specific contexts, and they didn't find that even those scenarios that were quite detailed were provided the adequate context. So again, we have much work to do on this study, and hopefully as we continue to complete these analyses, we'll have more specific recommendations based on the different stages of implementation and based on these different clinical treatments and contexts. So the second study that's sort of a spin-out of the ERIC project was to link these implementation strategies to a conceptual model of implementation. And we linked it to a model called the CFIR, or the Consolidated Framework for Implementation Research, which was developed by Laura Damschoter. Laura is actually the lead on this study. And she was interested in if we identified barriers using the CFIR, which is a consolidation of, I think, 19 different conceptual models in the field, if you're not familiar with it. And it includes 5 major domains. So it includes the characteristics of interventions, the characteristics of individuals, the inner setting, the outer setting, and implementation process. And within those 5 domains, there are 39 different subdomains. And so essentially we were interested in if we could match those barriers identified at each of those 39 subdomains to the types of strategies that may be effective at addressing them, so that we could prospectively identify barriers using the CFIR and then develop a thoughtful, tailored strategy based on those results. So for example, we phrased a barrier at the inner setting, focusing on relative priority as stakeholders perceive that implementation of the innovation takes a backseat to other initiatives or activities. And we asked people to select and rank up to 7 strategies that address that barrier. So we queried over 400 people and received about 170 responses. And we randomly assigned them to CFIR constructs and asked them to complete basically as many CFIR constructs as they were willing to complete. When they had become exhausted and were ready to be done with this, we directed them to some demographic questions. And essentially what we found was something sort of similar to the previous study that I shared. The average number of ERIC strategies ranked per CFIR construct, when you look across raters, was 47 strategies with a range of from 35 to 55. So for any given barrier, there were at least 35 strategies that were recommended to address that. The number of respondents varied per CFR construct, so we normalized these respondents as if there were 20 respondents for each of the constructs, and then developed tiers of recommendation. So if we had, based on these normalized results, at least 10 who endorsed the strategy, we called that a tier 1 star recommendation. So the majority of people think that this particular strategy would be effective at addressing this barrier. And if there were 4 to 9.5 people, it was a tier 1, 2 to 3.5, tier 2, 1 to 1.5, tier 3. So just for example, using the same construct of relative priority, we had just over 9 participants that endorsed this strategy. And so you can see that we had 0 tier 1 star recommendations for this. We had 6 strategies that reached the level of being a tier 1 recommendation, which means again that we had 4.5 to 9 participants that endorsed this strategy. 18 tier 2 strategies, 29 tier 3 strategies. When you look across all 39 constructs, I think this may be difficult to see, but the red bars here are the tier 1 star strategies, and so across all 39 constructs we had several strategies that there was consensus that these particular strategies are effective, at least in principle, at addressing these barriers. But as you can see, there's a wide range of responses, and we do a little bit better with tier 1 responses. So for most of these constructs, we have at least 10 strategies that we think might have a good chance of addressing these barriers. So this may be generous, but we have some loose consensus on the best strategies to address CFR barriers. Again, there's probably a need for more context. These people are answering these questions devoid of any context or clinical scenario, in an attempt to develop a generic tool that would be useful in a variety of settings. But we're hoping that this provides a starting point from which to build an evidence base for barrier-specific strategies, and that this can be a useful tool for people that want to go into a certain context, assess barriers and facilitators, and then pick some strategies that are likely to actually be effective in addressing those. And so would ask you to stay tuned for both the publications and a hopefully interactive tool that will be on cfrguide.org that will allow you to actually develop a tailored strategy using the online platform. I know I'm running out of time here, just wanted to briefly mention some work that I've done with colleagues to suggest potential methods for strengthening this linkage between barriers and facilitators and implementation strategies. And we suggest several methods, 2 of which I really hope are the focus of future work of mine, involving intervention mapping. Many of you are maybe familiar with intervention mapping from the field of health behavior. This is a systematic intervention protocol that really is designed to thoughtfully develop interventions using theory and evidence. And I think this can increasingly be applied to implementation science. I'm actually increasingly seeing publications in the journal Implementation Science and elsewhere that are bringing this method to bear in implementation. Group model building is actually a method from engineering that involves a structured process of developing more complex maps of implementation, sort of thinking about feedback loops and thinking about implementation from more of a systems perspective, and I think is another method that can be brought to bear. Again, I don't have time to do justice to these methods, but would point you to that paper if it's of interest. So I mentioned the importance of reporting implementation strategies in the literature, and there have been many people that have talked about how poor reporting actually really limits our ability to learn and build an evidence base for implementation. These are just 2 quotes that really were picked from systematic reviews at random. I think if you look at systematic reviews and meta-analyses in the field, you often see people bemoan the fact that poor reporting really precluded their ability to understand what was effective and why it was effective and what are the key sort of components or the core ingredients of implementation strategies that make them effective. And so there have been a number of efforts to develop reporting guidelines and to call for better reporting in implementation science. Susan Mickey and colleagues in 2009 wrote an editorial in Implementation Science that really called for this and suggested some guidelines called the wider guidelines or wider recommendations. And there's a checklist that I think is very helpful here by Albrecht and colleagues. We've developed some recommendations based on our reviews of implementation strategies, and there have been a number of other papers recently that have talked about reporting in implementation science. So just briefly, some of the recommendations that we have developed from our reviews call for people to really carefully name, define, and specify implementation strategies, hopefully using language that's consistent with the literature to the extent possible, and really specifying things like what actors are involved, what are the specific actions that they're taking, what are the targets of their implementation strategies. So what constructs are they targeting, what individuals, what levels are they targeting, temporality, what is the sequencing and the timing of implementation strategies, what is the dose or intensity of the strategy, and then what implementation outcome do we hypothesize should be affected? So is this strategy really designed to improve fidelity to an evidence-based treatment? Is it designed to improve sustainability or penetration, so on and so forth? And then importantly, what is the justification? So if we can provide a better theoretical, pragmatic, or empirical justification for our selection of implementation strategies, it will really help people to understand how and why these implementation strategies are effective. So I won't dwell on these examples, but there are a couple of examples in the literature of how these reporting guidelines have actually, I think, helped describe strategies. So this first is by a colleague, Alicia Bunger, at Ohio State University, who used this framework to report the implementation of trauma-focused cognitive behavioral therapy using a learning collaborative approach. And so learning collaborative in this case was actually a multifaceted strategy involving 11 component or discrete strategies. And so each of those component strategies was described in the detail that I just mentioned on the previous slide, which I think really gave us a better sense of what was going on in that specific implementation effort. Rachel Gold and colleagues from Oregon and Kaiser Permanente recently published an article using these guidelines in Mayo Clinic Review, and they apply this in an example specific to diabetes care if you're interested. Another, I think, good example of sort of an emerging framework is something called the Simplified Framework by Heather Colquhoun and colleagues. And this has been developed over a couple international meetings. I think I really commend them for convening stakeholders on an international level. And the second iteration of their guidelines can be seen here below this article. And they really ask people to specify the aims. So what do you want your strategy to achieve and for whom? The ingredients, what actually comprises the strategy, mechanism, how do you propose the strategy will work, and delivery. So how is the strategy actually delivered? And that's work that's ongoing. They're actually in the process of submitting an R01 to NIH to further develop that framework and hopefully use it to better design, evaluate, and report on implementation strategies. So I think there are a number of priorities moving forward, and Bianca certainly alluded to the need to develop evidence in this area, and I think that remains for both discrete strategies, for multifaceted strategies, and for blended strategies. We need more and better evidence for their effectiveness. I think we also need evidence for specific methods for developing and tailoring implementation strategies. So I'm not quite convinced that randomized control trials of specific implementation strategies will be definitive and generalizable to the breadth of context where implementation is occurring. So I think there's really a need for sort of generalizable processes over generalizable strategies, if you will. We also need more strategies at the patient, organizational, and policy level. Again, I think part of our work with the compilation has highlighted areas in which strategies are underrepresented. And I think there have been a number of other systematic reviews that have highlighted these gaps in implementation. So I think there is important work moving forward at all of these levels. I think we also need to develop organizational capacity in learning organizations. So as you all know, many of the organizations that we work with and the settings that we work with are not tasked with implementing a single practice. They're tasked with implementing many different practices, innovating and ex-novating, if you will, constantly. And so we need to really develop systems that can be adaptive and to utilize implementation strategies as needed in a systematic way. We also need to really think about mechanisms for change. So there's an increasing need to really understand how and why these implementation strategies work, and I think I've touched on that a little bit, but there's a great amount of work to be done in that area. And finally, reporting implementation processes and strategies is critical if we're really to develop a better evidence for this and to really understand how and why strategies are working. We need to focus on reporting. So thank you so much for the opportunity again. I want to take some time to acknowledge collaborators. I won't read them all by name, but most of this work is actually all of this work is teamwork, and I think that's really reflective of the field of implementation science, and I've had the benefit of working with some great colleagues. Also want to acknowledge funding from the Department of Veteran Affairs, the NIH, and the Doris Duke Charitable Foundation. And we'd be happy to take questions now, and I think we have some time later after Dr. Nielsen's talk to discuss some of this in more detail. So thank you again. Excellent. Fair enough. Thank you.
So there's a coffee break now outside. Per Nielsen will go on after that break, and then the two guys of them will be staying in the room. We have an opportunity to do some Q&A for 30 minutes before we go into lunch. So enjoy your coffee and be back in, what's that, half an hour? Yep. Huh? 45 minutes. And please, there are posters outside. There are poster presenters talking about their work. Enjoy them. Have a discussion with them. Thank you.